This session is really designed to be interactive, and delighted to have Robert David join me here, and we have Bob Gore running point on transcribing. I'm sure Linda's doing some of that as well. And our intent here is to really capture some immediate concrete actions that we can take to follow up our discussion today and apply them to the recommendations of the California Endowment Report that was released earlier today. So with your help, we can create this plan. This is interactive, but first, Bob, what's on your mind?
A couple of things I heard today. I mean, certainly I think a lot of people had caught their breath that, there was a significant amount of unspent mental health funds in this county.
Where'd Toby go?
Yeah, and the need's so great. I also heard, which might be a tie-in to that it sounded like there were not enough clinical placements for mental health students and mental health professionals. And maybe there's a good tie in there. Maybe there's a coalition that could come together. In my experience, it's always best, rather than in dribs and drabs, people go to the county board or the mental health leadership. Go as a coalition. Go as a coalition. Come together as a community and have a plan and an actionable plan and something that they can react to, and I think you might have some success. The other thing to Wayne's comments, and he's absolutely right, rural health care is suffering, not just in California, but in this country. A couple of things, though. For a hospital to reopen, the local community needs to step up and to decide, this is something we're going to support. We're going to go to this hospital. We're going to use this hospital. And the other thing he mentioned, successful facilities, they do have to really start thinking outside of the box and not do it the way they did before. You can't expect the board or anyone can't expect the hospital just to magically reopen and have all the exact same services, have all the same staffing levels, have everything just the same. Or you'll be back in the hole where you were before. And then finally, because there are, there's folks that like to buy hospitals and will promise the sky to rural communities. And you just have to be aware that if it sounds too good to be true, it probably is. So just take a good hard look at whoever's coming in and listen to Wayne. He's, has a lot of experience in leading this effort, and I commit to my departments. We'll do whatever we can to help you to get to where you need to be, because I know that it's tough.
I know you will.
50 miles away is a long ways to get acute care.
This is once in a lifetime, and this wasn't by design. There's 9% of the population that's left-handed. There's 100% of the people up here that are left-handed, I just noticed. So notice where we got our pens. So what does that tell you? But anyway, go ahead.
I am not sure what that tells us. It's probably not a good thing. But Bob, thank you for that, because in your comments earlier today, you really hit hard the explosion of the rural clinics through the ACA. You also talked about what I think many of us appreciated was some transparency with the pharma companies relative to evidence around increased costs. And then I think, too, a nice jewel was the Health Foundation's website. And I do love the idea that the scholarships in exchange for a service obligation. That is, I hope that everybody shares that with those seeking careers that might benefit from it. But you started with Toby in terms of the county piece, and Supervisor Neves, a little challenge for you here in terms of the county engagement relative to some of that funding. As you've heard, because you're a veteran at these, we have a concrete issue in the digital learning area of broadband access. I would suggest that we look at ways to leverage those dollars, go after them to help us solve this broadband challenge on the west side. There's plenty of money there. I think it'll require us to collaborate and cooperate. But I think that's a great takeaway strategy, kind of marrying these two, that ultimately supports this movement from getting care out of the hospital into the telehealth communities delivery services. Because if I've got students in Mendota that are taking an online class, they can't access a certification for some certification required for nursing. So I think that's a good takeaway there. As I think about a lot of what I heard today, a lot of great discussion threads, the high quality whole person services at the right time, the right level, and in the right place. Every educational provider in here today has to view themselves as being in the right place in the right time. And I think that level was really affirmed today of the important role that workforce providers play. The notion around, you heard earlier this morning with Sonia, and I know Richard Figueroa had to leave, but let's just, again, say thank you to the California Endowment, acknowledging that this is the first time those Healthcare Futures Workforce Commission recommendations were discussed in a public venue. I think that was a nice takeaway for today. Some other elements regarding that, I do think that the issue of behavioral health that the California Endowment recognizes is a really important one. But what else on your mind there, Bob?
Well, the one takeaway was, how did I miss investing in Cerner?
Yeah. Yeah. Yeah.
That was a total miss.
Yeah.
Oh, gosh. I would, we do have this program that's going on that I talked a little bit about, where paramedics are being tested in different ways, in actually a pretty promising way to, those of you in the hospital field, or certainly in the mental health field, know the term frequent flyers. And this is kind of what that's focused on, is those folks that continually you see in the emergency department again and again. If you can redirect them to mental health treatment centers. Now, the problem is there's not very many mental health treatment centers, but I guess Fresno County, they're testing this concept. There's other, come up with a good idea for to test a scope of practice, because clearly, having a health insurance card is great, and I'm glad that we've made significant strides there. But unless you have access to care, and we're not going to doctor our way out of this, there's just not going to be enough physicians coming in the pipeline, particularly in primary care. So we're going to have to expand through the team concept, other providers and other ways of delivering care. And I would just challenge you to be creative and to start, thinking about, California is such a diverse state. One size does not fit all. And I think too often Sacramento says, you will do this, and it doesn't fit everywhere. Mm-hmm. So I think a lot of the good ideas come from local communities and can be done on a local basis and tested on a local basis. Mm-hmm. So I would challenge you to start thinking about that.
I think to a great extent, Bob, the recognition and significance of the variety of services that many community colleges are being asked to provide have extended well beyond those issues we've talked about in the past: homelessness, food insecurities, and this rapid emergence of services to various constituent groups, veteran services, perhaps no more significant than the mental health and behavioral health services. And as we look at what is coming from Sacramento, while I do think there is a modest recognition, it is not a recognition that is sustainable. These are one-time dollars that are coming that are far insignificant for us to sustain services around mental and behavioral health as we increasingly try to comply with an uptick in state requirements. Are there some thoughts from Sacramento that you can share with us that might help community college leaders and local rural clinics and others collaborate to advocate and lobby for better, improved, sustained funding over the long term relative to some of these mental and behavioral health?
Well, I mean, we're going to have a new governor in another 6 weeks. one of his highest priorities is dealing with the homeless crisis, which is in pretty much every community in California. That's an aspirational goal, because there's no magic rabbit to pull out of the hat, but certainly connected very closely with the homeless crisis is mental health, and how are we delivering it, and how are we reaching people, and how are we doing that? So clearly that's one of the top areas, and I think he's going to be listening for creative ideas and maybe there are examples in particular communities that could be scaled too. It would not surprise me, and I'm not going to speak out of turn here, but if our friend Richard doesn't come back into government, so he's somebody I'd keep an eye on.
Mm-hmm. You know, I think another area I heard today, and this is all the practitioners, the outstanding faculty, the administrative staff, all of those associated with health careers, and really highlighted by the ongoing regional work of Valerie Fisher and some of her colleagues. But really expanding and replicating and funding these model health pipeline programs. But what I didn't necessarily hear today is, what is a pipeline program, and how do we calibrate that for community college, career, and tech ed? So I would suggest some of the takeaways for those practitioners, particularly the administrators that work closely with faculty on the development of emerging future directions around health career programs, is to collaborate on really helping colleges understand what that pipeline looks like. And whether it's latticed or braided or funded or whatever flavor of the month we want to call it, I think there's some work there. Obviously, there's some challenges as well with, as you heard Kathy DeFetti say, the clinical congestion. And then I would also say, where's that K-16 pipeline? What about the K-12 environment? And while we look for ways to create these pipelines, 6th, 8th graders, 8th graders, 10th graders, and dual enrollment is on the table. What are our options there for those mental health pathways? And then also, Bob, and anyone else that has at a senior level position like you in Sacramento, I would say that at some point there has to be a recognition that we are not serving adequate need of healthcare professions in California. And we must, as intersegmental partners in higher education, get over the territorial issue of siloing the inability of community colleges to provide bachelor's degree programs, particularly in nursing. It's long overdue. There's been 15 pilots that have been extended. We are not seeking to cause undue harm, to unnecessarily replicate four-year programs. What we're looking to do is fill codified shortages across these programs, and I truly hope that we can continue the legislative advocacy to elevate the role in a complementary, supplemental way with our California State University partners, because I think whether it's a California Health Corps or a Health Career Opportunity Program, we heard throughout the day, shortages here, shortages there, unmet need, inability to fill gaps, skilled shortages, succession planning, retirements. And I just think that there needs to be the shift amongst the three segments of American higher education to really provide the ability for community colleges to do that workforce training. So quite editorial there. I apologize for that, but it's long overdue. Some questions from the audience. What's on your mind? You've heard quite a bit today. What's that one concrete, actionable outcome you have in your mind? Go ahead, Nathan.
All right. So, it seems like that being located in Coalinga, long ways away from everything, it seems, we do have a lot of self-sustaining programs like schools, colleges. We have a lot of great things in Coalinga. Okay, here we go. So we have a lot of great things here in Coalinga, but it seems like all of the things that there's help for, they find a reason not to bring them to Coalinga. Like they say, hey, there's rural access for broadband, but they pick towns that are 20 miles away from large cities. Exact same thing in healthcare. If you look at where the major places are that say that they went out and they're promoting to rural places, they're only 20, 30 miles out. They're not going to places like Coalinga. And I think that we really need to work with Sacramento and say, hey, if you really want to work with rural places, we put a limit on population size and how far they have to be from a major population. And that's how we're going to get things done here in Coalinga and in other places. And if we don't do that, we're going to continue to see failure. We have Avenel, we have Huron, we have Coalinga. All of those places, I think, are very underserved in a lot of these different things. And I just, we have a lot of people here. The library, we finally got a 1 gigabyte connection. I would love to see some telehealth. Anyone interested in providing telehealth at the library, get a hold of me. We can do that. We can facilitate that. Got the director, involved. She wants to do things with our internet for the community. So at the library, we're trying to promote what we have out to the public and what we can do and work with people like West Hills College and whatnot. And so I just wanted to put that out there that, it seems like it's really hard for us. I've went to D.C., I've went to Sacramento. They have really encouraging words, but then when it comes down to it, to try and make those dollars make sense, that's where it sits at. So.
Yeah, and Nathan, thank you for that. Keep fighting the fight. There are statutes and regulations that foster this disinvestment. Many of them are so built on population density, and that really eliminates rural America. We'll continue to fight that fight. But on the telehealth, Eric, some comments there, please.
First of all, it's great being here today and hearing all the comments. Before I get to telehealth, let me go back to broadband, because we work with rural communities all over the state to get broadband deployed for healthcare purposes. What I would say to you as a community is it works best when the community comes together and comes up with a broadband plan. And if you do that around the anchor institutions like the library, the schools, clinics and hospitals, the formula that we see work most often is those are the anchor institutions that we use either federal or state dollars to get connectivity funded to, and then we find a way for that to bleed into the rest of the community because the providers have enough seed capital to get it started. Doesn't always work that way, but that's the first thing that we'd like to see happen. I'm happy to make myself available in that planning process, if that makes sense. On the telehealth side, yeah, we spoke about that earlier. There is an increasing awareness amongst the Department of Healthcare Services and other CMS and other agencies that actually pay for Medicare and Medi-Cal procedures that moving outside of the traditional bricks and mortar clinics and hospitals is the right thing to do. And as I mentioned earlier today, we're seeing that in terms of the expansion or the improvement in procedures that can now be reimbursed that are outside of the bricks and mortar environment. So I think suggestions like using the library where there is connectivity for telehealth consultations is more realistic now than it ever has been. So I look forward to following up with you. Obviously, the big issue in those instances is privacy. So if you have somebody that is seeking a virtual consultation, you need it to be in an environment where, from a HIPAA standpoint, people can't overhear the conversation and that kind of thing. But assuming that, but that's the kind of thinking we're going to need to do in order to get people served in rural areas. Because one thing we know is the traditional approach ain't going to work going forward. We got to come up with new ways of doing things.
Thank you, Eric. Some comments to that? I think another area that I was intrigued by, Nina, are you still here? Nina Plata from AH. Okay, she talked a little bit about this community health workers and some curriculum, and that some of these hospitals are beginning to do some of these community needs assessment, the 80% no-show rate on diabetes classes. Where are we at with community health workers curriculum? What's on the pipeline? Who are we engaging and interacting with? Is it something on the radar for West Hills now or any other Central Valley community colleges? Valerie, jump in.
Yes, it's been on the radar of quite a few colleges.
Valerie.
So yes, it's been on the radar of several community colleges in the valley. And my most recent attempt was in Fresno area, because if anyone has the quote-unquote bandwidth to develop one and have good number outputs, that would be in the Fresno area just due to the population. And basically, we held a preliminary planning meeting for that. And the advisory committee that was made up of local employers and primarily the public health officials of Fresno County told us not to bother to do it, that they did not have the funds to hire those types of people in their public health budget. So in order to really, that's a piece of our healthcare system that has a huge hole in it. It's called public health in general. And in order for them to be able to hire people to serve the community, we're going to have to increase their budgets.
You know, that's there's a great deal of interest in Sacramento about the role of promotorists and community health workers. You know, that's the kind of local project that I could see, like the California Endowment being very interested. I'm not putting words in Fig's mouth, but of potentially be interested in getting some data on community health workers, because I think a lot of it is a lack of data and probably a fear in Sacramento of taking on from a cost perspective a new healthcare
Yeah, actually, that
provider.
was one of my other problems is that, I'm required to find labor market data that shows that there is a job and that there's need in the area, and I could not find any job postings. And even if we go deeper and have our Center of Excellence data guru person do it, that's still not showing up on the radar for LMI data as a job that's in need for the Central Valley, unfortunately. Because I think we need it. I think we need them.
Yeah, and with all the continuing focus on clinically competent and culturally competent healthcare, I mean that's a real good connector there.
Hi, this is Joyce. So the hub that I keep mentioning, it's community health workers that we use. And again, I think there's opportunity in working with hospitals around the discharging process, because there's a lot of effort in care continuum is what the new term is that we're all being asked to be mindful of. So in that care continuum, I think we just have to keep being aware that these types of roles are out there, and then how do we maximize them and make sure that we're working together to use them.
Well, that's an excellent point, and you raised it yourself about readmission penalties. So hospitals are really interested in a continuum of care outside the hospital and not to see that patient again because there are financial penalties. So, you might have a captive audience with the hospitals.
And the interesting thing is that a lot of times it's not home health. It's someone to help make the doctor's appointments, to pick up the meds, to take them to the appointment. So that's the greatness of the community health worker. And then actually somebody that's stopping by, so if something's going south, they see it early to where they can report it up.
Just to follow up, if you wouldn't mind on that, or anybody else that can add in, one of the other pieces I heard relative to this approach was this social determinants, really impacting a lot of our programs. And what kind of training is being integrated around that so that all students in these health professions training programs can effectively improve the health of all those they serve?
I would want to look to one of my academic colleagues, because we know that when we hire them, we put them through an orientation and sign them off that they're going to fulfill what we want them to do when they go out. I can't speak to what they got trained on before they got to us, but I think, again, the collaboration around that. But I do know that and I'm blanking on his name, but the physician that works with the wonderful company that does the amazing community clinics and all the upstream and downstream and social determinants, it really is significant to go into the home and to see for yourself. And there's a very quick checklist that you can go through for, is there mold, is there roaches, is there other stuff in the environment that's going to lead to them
Yeah.
having the asthma or whatever's going on.
So then does it become an issue of scale? I mean, if we're seeing some examples of that going on out there, is there a role community college could provide to increase the scale of that training?
Potentially.
Yeah.
And is there someone that can speak to how they're trained today?
I would hope so. We have a,
Kathy?
I can say that often I have tried to work with our academic partners in allowing our nursing students to, when they discharge their patients in the hospital, to actually go and make a home visit to this patient afterwards. I think it would be advisable for them to see, okay, this is a patient I know. I did discharge this patient alongside with the nurse, but now I want to see where they live, how did that go, what did I miss? Because I think that's the critical thinking point that they need to have when they graduate and they start working. They need to understand those concepts, but I have trouble with that idea sometimes because I think some of the home health folks, they paid by the visit, they don't want to be slowed down, there's some other kinds of issues with that. So that makes it a little difficult in that respect. I know that, I think Fresno State has a relationship with somebody for that, but I've offered grants and all sorts of stuff, but I just can't make that happen right now,
okay.
from where
So
we're at.
Kathy, don't give that back yet. Just to follow up for you there, then, is there discussion or opportunities around establishing and scaling new universal home care worker family of jobs with career ladders and associated training?
Definitely. I think those are, again, they're going to be entry-level type roles. These
But
folks
they're
are going to eventually
you gotta get
move
your-
on. But, oh, absolutely. I think that's definitely a need. My mom is getting her wound vac today, and she's waited for 2 weeks for the wound vac. Okay, so there's some real serious problems that, we have in our systems, and this really isn't a person problem, it's a systems problem. We still have issues that, I couldn't believe it, who's ordering the wound vac, the physician's office or home health? I'm like, now that's a 30-year-old question, because I remember having these same conversations, and that the specialist in the office isn't ordering the vac. He ain't gonna do it. So, anyway, it's just one of those things. So, yes, I think then those individuals, that can help with those folks in between those areas of skilled need and not can definitely have an impact in that. But yes, that's definitely something we can do in our end.
Yeah. As we wrap up, anybody with some final comments? I'm really looking to provide you the opportunity for that one thing that's on your mind that we could put into our action report. Any final students? You're welcome to participate in this. Jump in there, James.
Up and in the rising in a lot of healthcare institutions is workplace violence, and I really think that needs to be addressed on a retention level.
Okay. And you're speaking about, yeah, right, okay, good. Valerie?
We need to add nursing faculty back on the loan repayment plan.
Longer payment plan?
Loan repayment plan.
Loan repayment plan. Is that an advocacy issue then? With some legislative decrees probably, somewhere down the line? Okay, good. Hey, you don't get the big money if you don't ask for the big money. So good job, Valerie. Anybody else? Yes? Need longer legs, Linda.
The fruit and tea woke me up, sorry. So I think we all have to be extremely mindful of incorporating our upcoming generations into the development of our curriculum and how they learn and how they will lead. So I don't think there's any time too soon as now, and I know that my academic colleagues are taking a look at that, but that's an issue on the service side as well. So there's, in nursing, we say you're continuous learners. That's actually part of your licensing. You will be a continuous learner. So I think we just have to all pause and really be mindful where we are with that and build that into our curriculum and into our onboarding and ongoing on the service side.
Yeah, no question. That's a good point. Nathan?
So we've been talking about preventative care, and I think one thing that speaks out to me is the food that we feed our kids at school. And my kids, through the first, eighth grades, I wouldn't let them eat the food at school because I'd seen what it was. And even though that they say that this meets the recommended daily guidelines of what they should eat, it's not what they should eat. I mean, not at all. And so I think healthcare really starts at what you put into your body. The food you eat, the air you breathe, the water you drink. And I think that making changes and promoting that, which is something that wouldn't even cost a ton of money, we could do that at all levels, and especially smaller rural cities like Kalinga, where we only have a few places to shop. We don't have a Trader Joe's. We don't have all those places that we love to go when we go out, Fresno and Hanford and places like that. And but at least we could do is promote at our school levels, which I actually love eating at the West Hills College cafeteria. I think that's some pretty great food. But at the other levels, if we could, promote healthy eating to our kids, we could save us a lot of money in the long run.
We appreciate that. And if you want to really step up and have an awesome meal, visit the Lemoore Student Union campus. A great cafeteria over there, too. So don't limit yourself, Nathan, to Coalinga. Along with the Starbucks. Yeah, we don't have a Trader Joe's, but we got a Starbucks right on campus. So. And you'd have the extraordinary rare opportunity of crossing paths with the CT Dean, Chris Costa, while you're there. So that's always a good thing.
And I just want to piggyback on that a little bit. I'm the Dean of the Allied Health, Physical Education, and Athletics Department at Fresno City College. And over the years, there's been a trend to do away with physical education because I think by the time you turn 18 and you're in college, you don't need it anymore. And it's not required anymore as for transfer requirements. It used to be part of our graduation. And there's kind of been a statement in so much as the funding goes that it's not important anymore to have PE. And I think most of us wouldn't want to take a PE course, and most of our students don't, but it goes along with, we're not teaching those values that it's important, and especially for a lot of the students that we see that have the food insecurity, they're not eating healthy, they're having the diabetes, they're having these issues, yet there's no repeatability. You can't take PE classes that will count for transfer anymore for the community, for the colleges. So we're not offering them as much. So I think that's missing a whole piece as well.
Well, and aside from the marginalization of the value of activity classes, I think there's a longer range impact as well. Those that participate in activities or athletics are much more likely to be absent less in the workforce, to be productive more in the workforce, will understand how to communicate, get along, critical thinking skills, conflict resolution. So it extends far beyond that activity class, and I appreciate your comment there. Another hand? Yes, ma'am.
I just wanted to add to that as well. I have a high schooler who sneaks off with a friend and goes with him in his car to fast food because they don't like the food on campus. It's not appealing. They don't like it. So then they sneak in candy bars and sell them. Yeah.
Well, that's a K-12 issue in terms of, I grew up in high school eating Braunschweiger sandwiches with mayonnaise. That's all my mom would give me. So the cafeteria food was a treat. So, all right, any final comments, Linda? Let me again issue my thanks to Bob Gore, the Gualco Group, the California Endowment for their outstanding participation today. Every single one of you that participated in developing your vision for what your purpose here today would be. Also, Bob, thank you for your ongoing work. We look forward to the next steps. We do, as always, take a couple of weeks to huddle and recover, and then we'll start crafting the outcome actions plan. And I would just invite you to visit our website, essentialelementsseries.com, which has all of that material. And long live all of you for what you do to support our communities. So thank you so very much for joining us today. Be safe out there.